Thank you, Chairman. It's my great honor and pleasure to take a last place in this session. And I'll talk the OACIS Registry in Japan for acute myocardial infarction. Lie down, please. Lie, please. Osaka Acute Coronary Insufficiency Study, and this is different from here, OACIS. This is C, it is not S. And AMI Registry in Osaka area, ongoing prospective multi-center observational study, started April 1988 and registered 12,000 cases by this month. And serum sample is more than 6,000, and DNA sample is almost 6,000. And data analysis of clinical demographics, therapeutic procedures, clinical outcomes up to 5 years. And 1 year follow-up rate is 93%. And look at the comparison with the GRACE Registry, United States National Registry for MI, and our OACIS. The total number is the GRACE is 44,000, United States 1.5 million, and OACIS is small at the 12,000, and involved institution numbers here. And criteria of enrollment in the GRACE study, acute coronary syndrome, and United States AMI, and OACIS of the AMI, but within 1 week of the onset. The big difference is in hospital stay, 6 days, 5 days, 22 days in Japan. In hospital deaths, however, the GRACE study is 5%, United States 10%, and OACIS is 8%. That means in hospital stay is much longer, so this figure is a very nice, in hospital death is a very small rate. And deperfusion percentage is very high in Japan, and most of the PCI. So the thrombolysis, the percentage is very low. This is very unique. Physicians prefer the PCI than the thrombolysis. And the follow-up is the United States is a large population, but in hospital follow-up only, we follow up 5 years. So we can discuss the prognosis of the patients. And look at this from 1998 to 2010, the age is getting older. However, sex difference is not big difference. And in Japan, the acute myocardial infarction is most of the male. The female is a very small percentage. And diabetes, in Japan, the obesity is a very small percentage. However, the comorbidity of diabetes are relatively high. So about less than 40%, 38%, and it doesn't change. Hypertension is almost 60%. And dyslipidemia is 40%. And smoking habit is extremely high, about 60%. But in general population in Japan, the smoking is at 23% or something like that. So the infarct patients is a smoking habit is 60%. This is the remarkably high. And the age is the 66, comparable. Gender is as I said, 75 is a male, and body weight is a big difference. And history of MI is much less in Japan, and diabetes is a little bit higher, and hypertension is comparable. Hyperlipidemia is even, despite the less obesity, diabetes is high, and hyperlipidemia is high, and the smoking is very high rate. And deperfusion therapy is almost 90% of the patients reperfusion therapy, and in hospital deaths is around, and we don't know why this is a slightly drop and increase again, but it's very hard to explain this. And in hospital outcome, as I said, the hospital stay is much longer than in Japan. And death rate is 70.6. Heart failure is much less. And this is the LVEF is a little bit higher, and heart failure is much less. Although VT-VF incidence is a little bit higher than the United States. So this is the outline of our registry, and we are talking about our study in this registry. As you know, the risk factors for myocardial infarction is the social or environmental risk factors, and also the genetic risk factors. This is combined to make a risk of the. This is a classical factors. Say that diabetes is the big difference in prognosis of the patient in this registry. However, there is a report that if you have one relatives among your family and relatives, then odds ratio increase 2 times. And if you have 2 or more relatives, then about 3 times odds ratios increase. That means genetic background is a very important risk factors. So we survey the Genome-wide association study, and single nucleotide polymorphism, SNPs, was studied. And we pick up the screening AMI 94 patients, and as a control without history of myocardial infarction, 658 patients, and genome-wide association study was performed. And we pick up the candidate of the SNPs which suspect of the myocardial infarction. So this is a p-value. This is a p-value. That means p less than 0.001 is 672 candidates for the SNPs. And this finally one is a p less than the 0.00006.5. So in this analysis, about 800 candidates for SNPs is picked up. And finally, we found that lymphotoxin alpha, intron 1, 252 codon A to G variation, so that the GG type is a higher incidence of myocardial infarctions. And lymphotoxin alpha is another name, TNF beta is another name of lymphotoxin alpha. That means it's involved in the inflammation. And this odds ratio is 1.7, around 1.7 if you have a GG allele in lymphotoxin alpha gene. And we studied functional studies. And this G allele means luciferase activity is high. That means transcriptional activity is high. The expression of lymphotoxin alpha gene is in high if you have this allele variations. And also in the culture study, we found this allele show that E-selectin VCAM1 adhesion molecule is high. So this SNPs may be increase the expression and also the activity of the adhesion molecule and commit to the inflammations. So in another study, to confirm the lymphotoxin alpha is important or not, we selected candidate gene which related to atherosclerosis. This is the RL system, catecholamine system, extracellular matrix, radicals, lipids, and platelet coagulation factors. So we pick up the 78 candidate gene and screen the SNPs and related to the onset of the infarction. Finally, the inflammation. And we pick up the several candidate genes which may relate or link to the myocardial infarction. And hepatic lipase, IL-4RA, IL-18, and this lymphotoxin A is the only p-value, is significant, and hazard ratio is 2.46. So in another studies, we confirmed that lymphotoxin alpha is a risk factors, risk gene in the SNPs in our registry study. And we have following up data. So the GG allele, this allele, and this is not a normal allele, then the survival is significantly decreased by this allele variations. Interestingly, if the patients receive the statin plus, and this is a statin minus, if the statin is administered, then this difference in mortality is disappeared. That means GGRL increase the probability of inflammation, atherosclerosis, and this is the bad for the prognosis. If you give the statin in the patients, this risk factors is canceled. So very interesting. And look at the LDL cholesterol distribution in this registry. And more than 130 milligram abnormally high is 41% in this registry. And we compare with this LDL cholesterol and CRP. There is no correlation. And we administer atorvastatin and pravastatin, simvastatin, fluvastatin in this dose. This is the Japanese dose, is a little bit smaller than the United States or Europe. However, statin is very effective. The patient who administered statin is the very good prognosis. And interestingly, this is the high cholesterol, and this is a normal cholesterol. There is no difference in the effect of the statin. So this data show that the effect of the statin is independent of the LDL cholesterol. However, CRP, if the CRP is high, then the statin is effective. CRP is low, statin doesn't work. So the statin, they reduce the LDL cholesterol, yes. However, the prognosis, in terms of the prognosis, administration or not administration is very important, independent of the value of the LDL cholesterol, but it depends on the CRP. So in this registry, we see the relatively low LDL cholesterol in Japanese population. Statin treatment is effective regardless of the cholesterol level of the admission. The statin treatment is effective, especially in the patient with the increased inflammatory reactions. that means the CRP, or the lymphotoxin alpha SNPs variation. And CRP is independent from LDL cholesterol. Finally, I'd like to give you some data that the beta blocker is the class 1 recommendation for the acute myocardial infarction. However, the evidence is an old area. That means before reperfusion therapy is so the old data, that means more than 10 years data, beta blocker is effective. And we analyze the effect of beta blocker in our registry. Then gray risk scale is less than 107, is a low risk. This is a middle risk. This is a high risk. Beta blocker is only effective in high-risk patients. So we have to consider the effect of beta blocker in the near future, because evidence is old evidence. Now the reperfusion intervention is 90% achieved. So at that time, the gray score high, then we have to administer beta blocker to improve the prognosis. However, in low-risk patients, beta blocker, it is not effective. So this is the only observational study. It's not the definite evidence, but it's very nice implications for the future therapy. Finally, I just squeeze the time, and from this registry, epidemiology on onset MI, the daily variations, weekly variations, risk factors is published in this journal. And interventions for MI, reperfusion therapy, and statin, thrombectomy, Myocardial beta blocker therapy is published here. And genetic, mostly SNPs of the gene is published. Not only the lymphotoxin alpha is another. Today, the talk is LDL-3, but in this case, LDL-2 is the risk factors for the myocardial infarction. And predictor of depression and infection of pylori, Helicobacter pylori, and chlamydia, and high-sensitive CRP, atrial fibrillation, and role of collaterals, and in hospital period, smoking, inflammation, carotid thickness, diabetes mellitus, and saturated fatty acid, and microRNA. So from this registry, and we follow up 5 years for each patient with a very high follow-up rate, more than 93% or 95% is from this registration study, we have new evidence. But as I said, this is not a random study. This is only the observational studies. We have to be very careful to make a definite conclusion. Thank you very much.